Welcome to Pulse Medicine Chest X-ray Interpretation. So, the black areas on an X-ray is area of lucency, while the white areas is area of opacity. So, why do this happen? Our X-ray beam passes through the body through different structures, for example bones, heart, lungs, and the density of all these structures is different. So our X-ray beam is that dense structure. For example bone, it cannot easily pass through, while lungs are not dense because they are filled with air. So always assume that the patient to which the X-ray belongs is facing you. So what is the reason for this? The right side of the chest X-ray is to your left, and the left side of the chest X-ray is your right. In this video tutorial, you will learn how to apply the PIPA and ABCDE mnemonic to assess the quality of a chest radiograph and to identify simple radiological presentation. Now, we'll begin by reviewing the PIPA and ABCDE mnemonic. The mnemonic stands for patient's information, inspiration, penetration, exposed area, rotation. NG, tube location, airway, breathing, circulation, diaphragm, and everything else. Now we will review each of these in turn, of beginning with the patient's information. Patient information should include name, review of clinical history, previous imaging, as this may provide valuable evidence in support of your initial diagnosis. The next 4 steps in mnemonic review the technical quality of the radiograph, starting with the inspiration. Inspiration is assessed by counting the anterior ribs. There should be 6 anterior ribs above the diaphragm. The 7th rib should penetrate to the diaphragm. If the 7th rib is above the diaphragm, this suggests hyperinflation. The criteria for adequate inspiration: you should be able to see 5 to 6 anterior ends of the ribs, 8 to 10 posterior ends of the ribs. Penetration. The next step is to identify how well the X-ray have penetrated the patient's thorax. Penetration is assessed by identifying any outline of the thoracic vertebrae through the heart shadow. So good X-ray penetrance is important because it helps you to identify pathology lying behind the heart shadow. The next one is exposure. To check exposure, you have to focus on the lower thoracic vertebrae. So you can see the margins of the lower thoracic vertebrae are barely visible to us. If this margin is clearly visible to us, means the X-ray is hyperexposure. If not visible to us, that means this X-ray is hypoexposed. So for adequate exposure, lower thoracic vertebrae margin should be barely visible. Also, you must be able to see all of the lung zone on the radiograph. If you cannot see them, you will not be able to make an reliable diagnosis. Now, rotation. The next step is to assess the rotation. This can be done by looking at the medial edges of the clavicles and drawing a line through the adjacent spinosus process. The distance between the edge of the clavicles and the line should be equal on each side. If the distance are unequal, this suggests that the rotation is present. This completes the technical analysis of the radiograph. The next step is to identify whether there are any abnormalities present. NG tube location. So, many students are frequently asked to confirm the location of NG tubes. If the NG tube is correctly placed, the tip of the tube should be seen in the gas bubble of the stomach below the left diaphragm. So the radiograph notice how the NG tube extends into the lower zone of the right lung. This situation, feeding should be avoided and the NG tube should be removed. Airway. The trachea is in the midline and bifurcates at the carina into the left and the right main bronchus. You should note the three presentations: the normal, deviated, and the narrowed airway. I think we have looked for normal airway. Now let's look at the deviated. There are many causes of the tracheal deviation, but they can be generally classified into these diseases that you pull the trachea towards the affected side as demonstrated here: lung collapse, lung fibrosis, and lung tumors, and those diseases that push the trachea away from effective side as shown here. Now let's look at narrow airway. This is uncommon presentation and usually occurs due to malignancy. Having reviewed the airway, the next step is to look at breathing. You quickly scan all 6 lung zones and consider whether they appear normal or not, white to dark, or have too many lines. Now, let's review the causes of the white lung. Common causes of the white lung include lung collapse, pleural effusion, and consolidation. Collapse presents with uniform opacity and tracheal deviation towards the affected side. Note, however, that tracheal deviation does not always occur. Now, let's look at pleural effusion. Effusion presents with a uniform opacity and tracheal deviation pushed away from the affected side. Consolidation presents as a localized patchy opacity with air bronchograms. Now, the first, dark lung. The dark lung is caused by 2 presentations. The first is COPD, chronic obstructive pulmonary disease. This presents with the hyperinflation, a low flat diaphragm, and a straight heart border. The pleura are not usually visible in healthy individuals. If the pleura are visible, it indicates the presence of pleural thickening, which is typically associated with mesothelioma. Inspect the borders of each lung to ensure lung markings extends all the way to the edges of the lung fields. The absence of lung markings is suggestive of pneumothorax. Fluid hydrothorax or blood hemothorax can accumulate in pleural space, resulting in an area of increased opacity of the chest X-ray. The next step is cardiac. Assess the heart size. In a healthy individual, the heart should occupy no more than 50% of the thoracic width, e.g., a cardiothoracic ratio of less than 0.5. The rule only applies to PA chest X-rays, as AP films exaggerate heart size, so you should not draw any conclusion about heart size from a film. Cardiomegaly is said to be present if the heart occupies more than 50% of the thoracic width on a PA chest X-ray. Cardiomegaly can develop for a wide variety of reasons, including a valvular heart disease, cardiomyopathy, pulmonary hypertension, and pericardial effusion. Assess the heart borders. Inspect the borders of the heart, which should be well defined in a healthy individual. The right atrium makes up most of the right heart border, and the left ventricle makes up most of the left heart border. The heart border may become difficult to distinguish from the lung field as a result of pathology, which increase the opacity of the overlying lung tissues. Reduced definition of the right heart border is typically associated with right middle lobe consolidation. The next step is diaphragm. In the normal radiograph, the right hemidiaphragm is superior to the left because it is displaced upward by the liver, and you should look for tenting of the diaphragm caused by phrenic nerve palsy or fibrosis. Look for white flakes on the surface of the diaphragm suggestive of asbestosis. Assess both costophrenic angles. Occurs in small pleural effusion as shown here. Look below diaphragm at the gas bubble in the stomach and for any free air beneath the diaphragm that suggests either a perforated stomach bowel or recent surgery. Now, finally, we review everything else. Starting in soft tissues, look for swelling, surgical epiphysema, and breast shadows. Next, look at the bones for any fractures or dislocation. Look at the clavicles, bones such as clavicles, scapula, humerus. Trace the outline of each rib.